you are
Eight
really
in one.
trying.
Yeah, I think that is. Yeah, it's breaking. I can't hear your voices. Actually, your voices are breaking. Anyway, so how long can we add? How many minutes more? Can we give them 5 minutes?
Okay, sir, let's give them 5 minutes. But before then, sir, please, I have a question about yesterday's lecture. I'm not the one not hearing, or I think the network.
Let me try looking in.
Can someone? Yeah, maybe. Hello, sir. Okay, can you try? Okay, he's Dr. What?
Hello, sir.
I'm actually the network provider for me because I'm suspecting that my mobile is not good. I'm trying to switch over to the MTN. Hello? Hello, everyone. Can you hear me now?
Yes, sir.
Okay, can we start?
Okay.
Okay, today we are going to talk about infertility. We're going to look at the definitions, the types of and incidence of infertility, the etiology, the evaluation of an infertile couple, in terms of history, examination, investigations, and look at some of the treatments. Of course, we're going to consider the psychological factors that are associated with infertility. Then we'll conclude. So next slide, please. Now, next slide. Infertility is a problem that affects couples all over the world. And of course, it is as old as mankind himself. It is estimated that 5 to 20% of all couples have infertility. In Africa, our situation is peculiar in the sense that while some couples are dealing with infertility, there's also a high fertility rate with a rapidly growing population. So we are having both sides. But of course, infertility is associated with significant psychosocial problems at individual, couple, and a family level because it imposes significant psychosocial stress. Next slide. What's the definition of infertility? Infertility is said to exist if a couple is unable to achieve a pregnancy after at least 1 year or more of regular in the sense that at least 2 to 2 times per week, unprotected, heterosexual, orgasmic, and ejaculatory vaginal intercourse with an adult of the opposite sex. This definition is important in this era where some people you don't even know what the gender you're going to use to describe them. So what's the incidence of infertility? Infertility affects roughly 10% of all couples, with the range of between 20 to 30% of couples, depending on the environment. And it accounts for at least 60% of gynae consultations in most clinics in Africa. Infertility can be classified as either primary, in which the couple have never achieved a pregnancy, or secondary, in which there's been a previous pregnancy, irrespective of the outcome of the pregnancy, whether the pregnancy ended as a miscarriage, as a preterm birth, as a molar pregnancy, it is immaterial because it was a pregnancy, and therefore such a couple is said to have secondary infertility. Next slide. In an environment, secondary infertility is said to predominate compared to primary infertility. Perhaps the reasons given may be genuine, but it may also be because in our environment, there's a desire for a larger family size. Women, 1, 2, 3 children may still want to have more. Unlike in the Western country where a woman with 1 child or 2 children will say it's enough, so she won't even seek consultation for infertility. So that could be the social factor that also account for more secondary infertility in our environment. Primary infertility accounts for 20% of infertility in the environment, while in the developed countries, primary infertility accounts for 80% of the infertility cases. Now, this reflects marked difference in the underlying etiology, where intrinsic factors such as chromosomal abnormalities, congenital and endocrine abnormalities predominate the etiology of infertility in Europe and North America. Whereas acquired factors such as infectious and environmental and operational factors are often found in association with infertility in developing countries. Next slide. It is now on average about 60% of married couples will achieve the pregnancy. Please, who's this person? iPhone, you are disturbing us. Okay. So it is estimated that 60% of couples will achieve the pregnancy within 6 months, and 90% of couples will achieve a pregnancy by the end of 1 year, which means by the end of 1 year, only about 10% of couples will not have achieved a pregnancy. And by the end of 24 months, that's 2 years, 95% of couples will have achieved the pregnancy. Therefore, you should also remember, with all this, there are factors that influence it. Key to that is age, particularly the age of the female partner. Infertility is highest between the ages of 18 and 24 for both males and females. Next slide. What are the goals in the management of an infertile couple, or your targets or your principles of management? One is to educate the couples about the requisites of normal fertility. So you want to counsel them about basic reproductive physiology in a layman's language. Don't talk to them like a doctor. Talk to them like somebody selling herbal medicine. So you know those guys can use real layman language. So use layman language to explain the basics of reproduction, the foundation. Then, of course, also one of the principles of care is provide emotional support for the couple, because they alone understand the extent of emotional stress they are facing. Then, of course, one of your goals or principle is to ensure that you conduct a thorough assessment, including history, thorough physical examination, and investigation. And of course, then that's when you'll be able to identify abnormalities and offer appropriate treatment, which would improve the chances of spontaneous conception, whether spontaneous or even artificial conception. Next slide. What are the contributions of the partners to infertility? The female partner is said to contribute roughly 30%. In 30% of infertile couples, the female partner is responsible. In another 30%, the male partner, while in another 30%, both partners in a couple are also involved, which means both have detectable abnormalities that might be responsible for the infertility. On the other hand, in 10% of couples, the exact cause of the infertility is not easily identifiable, and therefore it is classified as idiopathic. Next slide. Now, what are the factors essential for conception? For pregnancy to occur, the following criteria must be met. One, for the male partner must have normal male genital organs. For the female, she must have normal and functional female genital organs. Then, of course, for the male partner, there has to be normal production and migration of sperms along the male genital organs. And of course, there should be timely coitus, so that at coitus, the male partner is able to deposit live spermatozoa at the external cervical holes, which means the male partner must be able to achieve, sustain, and maintain erection, and as well as achieve ejaculation of the spermatozoa. So this is important. Next slide. Of course, in a female partner, the female partner must have a cervical mucus which is receptive, allowing the spermatozoa to swim along the female reproductive tract into the uterus through to the fallopian tube to allow for fertilization. And this with the proper migration of the sperm into the uterus and fallopian tube, which means the uterine size, the surface area of the uterine cavity must be normal, not elongated, not distorted by fibroids, not distorted by congenital abnormalities, for the sperm to move up and into the tube and then for fertilization. Then there has to be proper ovulation, or for the woman has to ovulate so that the sperms that have moved along the uterus into the tube will now be able to fertilize the egg. But of course, even after ovulation, there has to be ovum pickup. The fimbrial end of the fallopian tube have to be free and okay to pick up the released oocyte into the tube for ovulation to occur. And of course, the tube has to be patent enough to allow for spermatozoa, which are the motile gametes, to move into the tube to reach the ampulla where fertilization takes place. And of course, there has to be perfect penetration of the sperm into the ovum. And of course, after this, there has to be proper migration of the fertilized ovum through the fallopian tube back into the intrauterine cavity for implantation, which means the tube must not be diseased such that it will hamper the migration of the fertilized ovum back into the endometrial cavity. Because if that is happening, that will lead to the formation of ectopic pregnancy. Next slide. Again, no, next slide. Next. Okay, what? You look at this diagram, you understand on the right side, it shows you how the spermatozoa move along the tube and how the fertilized ovum eventually comes back to implant in the endometrial cavity. These functions require coordinated endocrine interaction between various endocrine glands in the body, right from the hypothalamus, pituitary, then the ovary, while in the male, the testicles, for this to happen. Next slide. So what are the causes of infertility? In the male, the causes of infertility could be defined or classified based on their relationship with the testicles. Now, the causes could be classified into pre-testicular. These are problems that are all related to the testicles, which means there could be systemic problems or local problems. Systemic problems that are pre-testicular include endocrine abnormalities like gonadotrophin deficiency, obesity, thyroid dysfunction, hyperprolactinemia. Now, other pre-testicular problems are not endocrine but psychosexual. This could include erectile dysfunction and impotence. Next slide. The next group is of course, other pre-testicular problems include drugs such as antihypertensives and antipsychotics. Yes, and some antihypertensives are associated with ED, erectile dysfunction, and therefore they can affect the ability for a couple to achieve conception. Other drugs such as antipsychotics may cause either premature ejaculation or lead to the formation of either premature ejaculation, even any ejaculation. The other pre-testicular problems include genetic problems, such as Klinefelter syndrome, which have, in this case, we have defective gonadal formation, and therefore there will be defective production of spermatozoa. You have other genetic abnormalities, such as Y chromosome deletions, other single gene mutations. Next slide. Now, you have pre-testicular, you have testicular and post-testicular. Now, testicular causes of male infertility include problems with ciliary movement. Now, we have what is called Cartagena syndrome, in which there are problems with the cilia, and therefore the spermatozoa is not able to move. You have other problems at the level of testes, such as infective conditions like mumps. Mumps is a viral infection that when it happens, when it affects the testicles, it will lead to the death of the primordial cells that form the spermatocyte. So spermatogonia will be killed. Other problems include toxins, which include drugs, cigarette smoking, alcoholism, radiation, then physical problems such as heat. Except that's why it is said that men that tend to wear tight-fitting clothes, tight-fitting underwears are associated with increased risk of infertility. The reason is that the testicular temperature gets high, and therefore that will affect spermatogenesis. Other testicular problems such as varicocele. In varicocele, what happens is that the pampiniform venous plexuses become dilated. And because they are dilated, the countercurrent exchange mechanism that controls the temperature within the testicle is lost, and therefore the temperature within the testis is high, and spermatogenesis is affected. Another problem, acquired problem that can happen includes testicular torsion. An individual who has had repeated episode of testicular torsion is at risk of having testicular ischemia, and therefore problem with spermatogenesis occurring. Immunological problems, connective tissue diseases, and other immunological diseases can also cause problems with spermatogenesis. Next slide. This slide talks about the post-testicular problems. So if you look at it, pre-testicular, usually systemic problems or endocrine problems. Then, of course, and drugs and other diseases and psychological stress. Then testicular problems that affect the testis itself. Then post-testicular problems. These are causes that are beyond, it means the testis is okay, it's forming the sperm cells, but it's a problem along the, what do you call it, plumbing system. Now, these defects, post-testicular problems could be congenital or acquired. Congenital post-testicular problems include congenital absence of the vas deferens. So men are born congenitally malformed or deformed vas deferens, and therefore they are unable to, the spermatozoa is unable to move from the testis through the urethra and into, for it to be deposited at the tip of the spermatozoa. Acquired problems such as infections like tuberculosis, gonorrhea, chlamydia also affect fertility. And of course, some of these problems could be acquired. When you visit a quack and the quack performs unwarranted surgery in the groin or in the scrotum, these problems include poorly performed herniorrhaphy or poorly performed vasectomy or vasectomy reversal. You know, when you are doing herniorrhaphy, you're supposed to identify the hernia sac, identify the spermatic cord. If the joker didn't identify the spermatic cord, you tie everything, and there will be testicular ischemia, and eventually there will be infertility. Other problems include congenital disorders such as hypospadias, where there's a defect associated with the opening of the urethra. And in this case, most of the time, hypospadia is associated with undescended testes, and therefore there will be problem of spermatogenesis as well as problem of depositing the sperm at the right place. You can also have a problem such as retrograde ejaculation. In this case, during orgasm, instead of the spermatozoa to be ejected and anterograde, they move backward into the bladder. This one is easily solved. You can centrifuge the postcoital urine and then do IUI with the sediment. There can also be errors in the seminal fluid, such as abnormal motility, abnormal morphology, high or low volume, undue viscosity. But most of these problems are due to either biochemical problems or chronic infections, such as prostatitis or chronic epididymolysis. Next slide. What are the causes of female factor infertility? Female factor infertility could be due to local anatomic problems, such as congenital absence of the vagina, or a blind ending vagina, or vaginal atresia, transverse vaginal septum, in which the spermatozoa is not able to ascend up into the uterus and into the tubes. May also be due to difficulty with coitus, due to a narrow introitus, or infective problems such as vaginitis. But this is not a major problem. Next slide. Cervical factors will also lead to infertility, and the result is that it will lead to ineffective sperm penetration because a diseased cervix is unable to produce appropriate and adequate amount of cervical secretion, which provides lubrication and allows for sperm migration. And it was said to account for 5% of infertility and may result from chronic cervicitis. Now, it can be diagnosed by detecting the presence of anti-sperm antibodies when during immunological test. Next slide. Uterine factor. Uterine factor is said to account for 10% of female infertility. The causes of uterine infertility could be such as tuberculous endometritis, which will result in adhesion formation. It could also be congenital, such as congenital uterine abnormality like didelphys, biconate. So many of these abnormalities can result in infertility. It could be due to uterine adhesion, such as Asherman syndrome or uterine synechia, or the presence of fibroids around the corner of the uterus, which will elongate the endometrium, distort it, and do not prevent spermatozoa from getting access into the ostia and into the tubes. Tubal factor is the most important cause of female infertility. It accounts for 25 to 35% of cases, and it's mainly due to tubal infection, which will lead to tubal blockage. It can also occur due to following tubal endometriosis or pelvic endometriosis, and it can also result from a grossly normal tube with altered tubal motility, either due to hormonal factors or due to microscopic injuries at the level of the cilia or the tubes. Next slide. Okay. Now, ovarian factors. Ovarian infertility results from defect in the coordinated interaction between the hypothalamus, pituitary, and ovarian axis. And in this case, the problems that could occur include hypergonadotrophic hypogonadism, in which case the problem is at the level of the ovary, in which case the hormones produced by the ovary are low, estrogen, progesterone level is low, but the gonadotrophins produced by the pituitary are high because there's a follicle stimulating hormone and neutralizing hormone. And the reason why their level is high is because the pituitary has been trying to increase the secretion of its own hormones to stimulate the ovary to produce egg and produce the other secondary hormones. So that is called hypergonadotrophic hypogonadism. In this case, you have high follicle stimulating hormone, high neutralizing hormone, low estrogen, and low progesterone. Then you can have another entity called hypogonadotrophic hypogonadism. In this case, both the gonadotrophins, that's the FSH, LH, are low, while, and at the same time, the ovarian hormones, estrogen, and progesterone are also low. An example of causes of hypogonadotrophic hypogonadism include Kalman syndrome, anorexia nervosa, amenorrhea that occurs in women who engage in strenuous physical activities or who are extremely stressed. It can also occur in women with pituitary tumor or who have CNS infection or who has infarction or ischemia around the pituitary. In this case, the main problem is you have to get gonadotrophins
for it to get the ovaries to bear. The problem is not at the level of the ovary, the problem is at the level of the higher centers, either the hypothalamus or the pituitary. Then you have ovarian dysfunction or eugonadotrophic hypogonadism, such as polycystic ovary syndrome. The level of the estrogen progestogen is low, but estrogen may be low or low normal, while the pituitary hormones are usually of the normal level or slightly elevated. Other discrete diseases that can cause ovarian infertility include hypothyroidism and hyperthyroidism, which will affect ovulation. Next slide. Now, we said polycystic ovarian syndrome is one of the types of ovarian or cause of ovarian infertility. And it is characterized by eugonadotrophic hypogonadism. The most common form of PCOS is the most common form of ovulatory dysfunction. It is estimated to affect up to 6 to 10% of women. The clinical and biochemical features of this syndrome are heterogeneous, and the combination and degree of expression of these features varies between individuals. Yes, in some women, you see those periods, you see them with classical features, hyperandrogenism, obesity, oligomenorrhea, and what have you. Others, the things may not be very, very clear, may not be very distinct. It is characterized by hyperestrogenic, hyperandrogenic, chronic anovulation. This is the main characteristic of polycystic ovarian syndrome. Hyperestrogenic, hyperandrogenic, chronic anovulation. It may present clinically with various ovulatory and menstrual disorders, infertility, or signs of androgen excess, such as acne or hirsutism, and obesity. Elevated serum LS levels are also a common feature of polycystic ovarian syndrome. Polycystic ovarian syndrome is also associated with long-term health consequences. And these long-term health consequences of polycystic ovarian syndrome include hyperinsulinemia and insulin resistance, and impaired pancreatic B-cell function, and therefore increased risk of type 2 diabetes. There's also risk of obesity, hyperlipidemia, and increased risk of cardiovascular disease. So if they ask you, list four long-term complications or long-term diseases associated with polycystic ovarian syndrome. So you have, don't go and put hirsutism, acne. Long-term problems include type 2 diabetes, obesity, hyperlipidemia, and increased risk of cardiovascular disease. Now, chronic anovulation in women with PCOS also increased risk of endometrial cancer. The reason is this: in PCOS, there's no ovulation is impaired. So a woman may go for 2, 3, 4, 5, 6 months without ovulation, without seeing her menses because she does not ovulate. And during that period, the estrogen level is either normal or low normal, but it has been chronically stimulating the endometrium to grow. That stimulation of endometrium that is prolonged for a longer period without commensurate action of progestogen will result in increased risk of endometrial hyperplasia, which may undergo malignant transformation and turn into an endometrial cancer. Next slide. Now, how do you diagnose polycystic ovarian syndrome? This is what is called the Rotterdam criteria, which comprises three criteria, but the presence of two suffices for the diagnosis of polycystic ovarian syndrome. One, oligo-ovulation or anovulation. That's the first criteria. Oligo-ovulation or anovulation, which manifests as what? Clinically, amenorrhea or oligomenorrhea. Then clinical and or biochemical signs of hyperandrogenism. That's the second criteria. Clinical and or biochemical, which means what do you see clinically to diagnose hyperandrogenism? One, hirsutism, abnormal hair growth in a woman. There's a normal expected pattern of hair growth for women, and there's an abnormal pattern of hair growth. So when you see abnormal hair growth, such as gemu, gashin baki, unnecessary growth of hair beyond the level of the navel, along the midline towards the chest, then that is a male pattern of hair distribution. Another evidence of clinical evidence of hyperandrogenism is acne, pimples, the current pimple that does not go. You know, pimples is common in the adolescent, but this one, it's beyond adolescent, the pimple is not going. And then she has infertility, she does not ovulate. You know, that is most likely PCOS. Then, of course, another thing is what? Sometimes it is not hirsutism, but baldness. You see a woman having head like a man's head with baldness, hair receding from the frontal region so fast. The third criteria is the presence of polycystic ovaries. That is the presence of 12 or more peripherally placed ovarian follicles that measure 2 to 9 millimeters in diameter. So when you look at the ovary, you see around the ovary at the periphery, 12 or more ovarian follicles that measure between 2 to 9 millimeters, and then they are arranged like a necklace around the neck. So this is typical finding of polycystic ovary syndrome. Or when you measure the ovarian volume and it's more than 10 mils, it tells you this polycystic ovarian syndrome. Next slide. Now, this is the picture of how polycystic ovarian syndrome appears. You see the follicles are arranged peripherally around the ovary. And if you measure the ovarian size, there's increased volume of the ovary, which tells you there's been excessive androgen synthesis. Next slide. Now, this diagnosis is done, ultrasonic diagnosis of polycystic ovaries is done using transvaginal ultrasound probe. Transabdominal does not readily diagnose it for you, except if it is a very high resolution transabdominal probe that you use. This is a 2D scan, transvaginal scan of the next slide. So, what about tuberculosis of the genital tract? Where does it affect and how does it manifest? Tuberculosis of the genital tract is acquired either through hematogenous dissemination or airborne like pulmonary tuberculosis. And in the genital tract, it first affects the fallopian tube and can cause what do you call it? It can cause abnormality, it can cause fallopian tube blockage leading to infertility. At the level of the endometrium, it can cause uterine synechia, Nash-Hammond syndrome. And of course, the underlying cause is the microbiological cause is what? Mycobacterium tuberculosis. And when a patient has tuberculosis, genital tuberculosis, she may have secondary focus of the tuberculosis elsewhere in the body or in the lungs. And of course, they may be associated tuber blockade. And clinically, it may manifest with menorrhagia, amenorrhea, and oligomenorrhea. Next slide. Now, what is pelvic inflammatory? What is pelvic inflammatory disease? It's an ascending infection from the lower genital tract to the upper genital tract, affecting the uterus, fallopian tubes, and adjacent pelvic structures that is not associated with surgery or pregnancy. So it means if it's something from the lower genital tract, which means from the cervix, vaginal cervix, then affecting the uterine cavity, fallopian tubes, and pelvic peritoneum and adjacent structures, which means it's usually vaginitis or cervicitis that leads to endometritis, then salpingitis, parametritis, and may now lead to oophorytis, tubo-ovarian abscess, or pelvic peritonitis. This is the ascending pathophysiology of pelvic inflammatory disease. Pelvic inflammatory disease is caused by sexually transmitted organisms, such as Neisseria gonorrhoeae, Chlamydia trachomatis, genital tract mycoplasma, that's Mycoplasma hominis, viruses and protozoa, herpes simplex, cytomegalovirus, and Trichomonas vaginalis. Of great importance are the bacterial causes, the first four, the first three actually. Next slide. What is luteinized or rupture follicular syndrome? Normally, during follicular development, the follicles grow. Eventually, one predominates, becomes the bigger one, and then while it becomes bigger, it has more receptors for follicle-stimulating hormone and luteinizing hormone. Then, when it has grown significantly, it will be producing copious amount of estrogen, and the high or rising level of estrogen will trigger a positive feedback that will cause a surge in the level of luteinizing hormone, and that will trigger ovulation. Now, sometimes this process will take place and ovulation will not take place, which means the ovum will not be released and therefore it will remain trapped within the ovary. But then if it is not released, it will still undergo changes that usually occur. And that is what is called luteinization, which means as soon as it is not released, the cells around the follicle will undergo changes and they will start producing lots of progesterone as if it's a corpus luteum that has been formed. But luteinized unruptured follicular syndrome is more common when there's pelvic endometriosis or when there's hyperprolactinemia or there's prolonged use of non-steroidal anti-inflammatory drugs. Because it is said that ovulation itself ovulation involves a lot of inflammatory mediators that may be affected by prolonged use of non-steroidal anti-inflammatory agents. Next slide. Next slide. Hello. Okay. It is now what is luteal phase defect? Now, it is associated with inadequate growth and function of the corpus luteum. Now, after ovulation in a normal steady state, after ovulation, the oocyte is released. But what remains behind of the follicle is converted to corpus luteum. And the corpus luteum produces progesterone to stimulate secretory changes in the endometrial cavity in preparation for possible pregnancy and implantation. Now, if pregnancy does not take place, that's if the egg is not fertilized, the corpus luteum will keep on producing progesterone for the number of days after ovulation. And the ovulation, the level of progesterone will peak by day 7 and subsequently start declining. And because of that decline, gradually the support the progesterone is giving the endometrium will be lost, and therefore the tissue, the endometrial growth will be shed off as menstrual blood. On the other hand, if pregnancy occurs, the corpus luteum will be producing progesterone, and then the progesterone will maintain the pregnancy, and the pregnancy will be producing HCG. The HCG will be providing stimulation for the corpus luteum to be working until the placenta is produced and is matured by around 12 to 14 weeks. So which means if the corpus luteum production of progesterone can be adequate or inadequate, whenever the corpus luteum is inadequately formed, it will produce inadequate progesterone, and therefore there will be defective either folliculogenesis or there will be defective implantation. And because of that, the decreased level of follicle-stimulating hormone and luteinizing hormone and elevated level of prolactin. Next slide. So, what about other factors that affect fertility? It includes subclinical hypothyroidism, advanced age, particularly maternal age, pelvic endometriosis, and dysfunctional uterine bleeding. Dysfunctional uterine bleeding is any bleeding from the genital tract whose etiology has not been identified yet, whose etiology is merely functional rather than anatomic. Next slide. So we'll talk about uterine factor. Now we're talking about tubal factor, not peritoneal factor. Pelvic adhesions after a surgery or previous infection. And these adhesions can distort the anatomy, the contour, the patency of the tube, and lead to tubal damage. Now, so we say that in some couple, about 10%, the infertility causes are not being, the investigating physician or the hospital is not able to define or identify the exact cause of the infertility. As such, in them, the infertility is unexplained because there's no identifiable cause. Next slide. Now, we said in about 30%, both the male and female partners are equally affected, and therefore, infertility is multifactorial in them. This could include when you have a woman with advanced maternal age and a husband with abnormal sperm parameters, or when the couple is having infrequent sexual intercourse, or they lack knowledge about coital technique, or there's poor timing of the coitus, and of course, there's also anxiety and depression. Other potential causes include the use of lubricants during intercourse, especially lubricants that contain spermicides, which the user does not know. And then he's using them during coitus, and you want the wife to get pregnant. It will not happen because the lubricant he's using is already cleaning the sperm cells before they are able to even swim along the entire tract. Next slide. Next slide, please, Salima. Okay, how do you investigate infertility? Before you investigate, you must have clear objectives. Your objectives include to detect the etiological factors and they have to rectify any abnormality that will help improve the fertility. And of course, to give assurance to the couple, the explanation when no abnormality is detected. So you've investigated everything and there's no problem. You didn't find any abnormal sperm parameter in the man. You didn't find any tubal problem with the man. You didn't find any ovulatory problem with the woman. So you explain to them that this is a situation they should keep on trying and they should be more patient. Next slide. So how do you explain to them? Or evaluation of the couple. 1, history, physical examination, investigation, then treatment. Next slide. Next, in the history, in the female, you take the history of her, of course, you include her, ask of her age, her parity, previous pregnancy outcome, and any previous complications in the course of the pregnancy, due to antenatal care, labor, and delivery. And of course, I take a menstrual history, the length of the cycle, the characteristic, the onset of menses, severity of dysmenorrhea, and whether she has any other menses. Then, of course, you ask for the history of coital frequency and any sexual dysfunction. Yes, a couple has come to you with infertility, but you must ask about the number of times she and her husband meet in a week, and then whether everything is okay with their sexual relationship. Because sometimes you find out that couples who have been looking for pregnancy for a while, after a while, they start telling themselves it is no benefit to have sexual intercourse with Mr. A or my wife or my husband, because I would still not get pregnant. So they lose interest, and that affects their sexual relationship significantly. So you have to also take a history about the duration of infertility and any previous evaluation and treatment, and where and when. Of course, take a history of past surgery, the indication of the surgery, outcome of the surgery, the past and present or past or current medical illness, including drug therapy, exposure, while also trying to exclude episode of PID or exposure to STI. It is important that when you're taking history of medications or past surgery, we take the history of drugs, because the person will be taking a drug that will affect his fertility. Next slide. You also take a history of other gynecology, such as history of previous abnormal pap smear and whether anything has been done, history of current medications and allergies, history of occupation, tobacco smoking, cigarette smoking, other drug use, families of birth defects, mental retardation, early menopause, or reproductive failure. Then a symptom, the presence of, ask for the presence of symptoms suggestive of thyroid disease, pelvic abdominal pain, galactoria, associated and dysphoria. Next slide. For the male partner, of course, the age is important. Previous paternity, has he given birth to another woman? Past his occupation, developmental history. At what age did he notice the voice changes when he started developing pubic hair, axillary hair? Then, what about facial hair? Also, take for the history of any childhood mumps, undescended testes, or brain surgery or trauma. And of course, medical history, history of drugs, substance use history, use of tobacco, hard drugs, or caffeine, the history of STIs and treatment. The medical, sexual history, frequency, and number of partners. Okay, now next slide. Of course, the history of ED, erectile dysfunction, is important. Next slide. Now, when you examine what are the things you examine in a patient who is seeking to conceive? Of course, take the weight and height, because the body mass index is also related to the characteristics of the menstrual cycle. Check and examine the neck for any anterior neck swelling, any nodules or tenderness. You do examine the breast and try to ask her to apply pressure so that if there's any breast secretions in their character, then examine the patient for signs of androgen excess, hirsutism, voice changes, acne. Then, of course, you examine for pelvic abdominal tenderness, the presence of any mass or enlargement. Of course, you do a cervical examination to assess a vaginal cervical abnormality, nodularity in the anterior cul-de-sac, or in the nasal anterior or the cul-de-sac. Next slide. Next slide, please. For the male, you also take the body mass index, examine for the general physique of the man. Does he have the typical male physique, or is the man looking more feminine? Then do a systemic examination, including abdominal and GI examination. You do a urogenital system examination. Examine the penis, the phallus, the scrotum. You do a digital rectal to assess the prostate. And of course, you also assess the anal orifices. Next slide. So for the female, what are the investigations you do? You do hormonal profile, you include day 1 or day 2 or 3 follicle stimulating hormone, luteinizing hormone, and estradiol, that's E2 estrogen. Then prolactin, thyroid hormone, and prolactin and thyroid hormone. You also do the test. Then you may also do other specific hormonal tests depending on the history and finding of examination. Of course, the woman can have laparoscopy, hysteroscopy, and endometrial biopsy, depending on the circumstance of going. Of course, the primary test for assessing the female infertile patient is to do HSG and blood acid. HSG, if the result from HSG says the tubes are patent, you don't need to go ahead and do laparoscopy. But when the HSG says the tubes are closed, you need to do laparoscopy to assess the veracity of this discovery. Next slide. Next slide. Now, what about the hysterosalpingography? It is a fluoroscopic study performed by inserting the opaque dye into the trunk cavity through a catheter to determine the contour of the endometrial cavity and the patency of the fallopian tubes. Abnormal findings include congenital malformations of the uterus, semicose myoma, uterine synechia, intrauterine polyps, and proximal or distal tubal occlusion. So HSG can help you diagnose this, but the problem with it is that if it tells you that the tube is closed, it is not likely, it may not be actually closed. The echocardiograph can be obtained in an outpatient setting. Next slide. Now, it is best done day 2 to 5 after menstruation has ceased. It is generally done in the first 10 days of the menstrual cycle, usually 2 to 5 days after the end of the menses, because this would minimize the risk of infection, avoid interference in the imaging by blood clots, and then avoid unrecognized conception cycles. If a woman has conceived and you didn't know or give her the grace to determine it, and now you say you want to do HSG for her, the HSG may result in the loss of an undiagnosed pregnancy. Of course, you provide routine analgesia, routine antibiotics, and schedule weeks or follow-up after acute PID. Next slide. So this is a hysterosynograph result. Next slide. That one. Next slide. So what laparoscopy and dye test? It is an endoscopic procedure done to inspect the content of the peritoneal cavity through abdominal wall. It is the gold standard for the evaluation of tubal factor infertility. Tubal abnormalities such as agglutinated fimbria and adhesions, which restrict motion of the tubes, or peritubal cyst, may suggest tubal disease that would not be easily detected by hysterosynography. The diagnosis of endometriosis is usually based on laparoscopic findings, and therefore, when you do lap and dye, you may diagnose endometriosis as the underlying cause of the tubal disease. Features of Fish-Hugh-Curtis syndrome will also be detected, which is perihepatitis, also hepatic adhesions, which suggest chronic infection or the active infection to a familial pelvic inflammatory disease. Next slide. Hysteroscopy is an endoscopic procedure done to visualize the endometrial cavity through the cervical uterine cervix. The telescope used can be rigid or flexible, and liquid or gas or other non-electrolyte solutions such as glycine and dextran can be used as the standing medium so that the endometrial cavity will be inspected. It has both diagnostic and therapeutic indications. Next slide. This is the hysteroscopy setup. You have, this is endometrial pathology after taking a biopsy for uterine bleeding. Next slide. Asherman syndrome. This is where you have intrauterine adhesions. Next slide. The potential findings at the hysteroscopy include intrauterine adhesions, submucous fibroids, endometrial polyps, and endometriotic cysts within the endometrial cavity. Next slide. Sonohysterosynography. It was originally observed that fluid accumulation in the cord of Douglas is possible, and this indicates that the tubes are patent. This is what they call hydrotubation. They will pass to They will pass catheter into the endometrial cavity and push in the contrast, which usually contrast is like it's a surfactant that produces macro bubbles when stimulated by ultrasound. And then a three-dimensional transvaginal ultrasound is done, which will generate images, and that will be interpreted to assess the tubal potency. In addition to sonohysterosalpingography, Doppler techniques can also improve visualization of the fluid movement through the fallopian tubes. Next slide. Now, transvaginal sonography also be able to identify to examine the ovarian morphology, they diagnose multiple follicles of polycystic ovarian syndrome, identify the presence of ovarian cysts, measure ovarian volume, assess, provide access for oocyte retrieval, a guide for oocyte retrieval, and of course, detect the presence of uterine abnormalities, and of course, measure endometrial thickness. Next slide. So for ovarian factor infertility, how do you measure it? Well, the basal body temperature method was used in the past, in which it is based on the biphasic pattern of temperature around the time of ovulation due to a secondary rise in progesterone level. It is associated with increased level of norepinephrine, and both of them are thermogenic. Oral temperature is checked by the patient every morning before getting. Next slide. Temperature rises by 0.2 to 0.5 degrees Celsius and maintained throughout the second half of the cycle. This demonstrable rise in temperature occurs about 2 hours after the LH peak. Peripheral level of progesterone is greater than 5 nanograms per ml for 2 days prior to the next period. Basal body temperature helps in determining ovulation, timing of postcoital test, endometrial biopsy, cervical mucus, vaginal cytology study for ovulation. Next slide. Serum progesterone concentration is used to diagnose ovulation. That's day 21 progesterone. It's usually done on day 21. This is known as luteal phase progesterone. Now, when you say day 21, you are assuming that the woman has a textbook cycle of 28 days. And if she doesn't have that one, if you don't take the menstrual IC, you have difficulty measuring progesterone to diagnose ovulation. The value of more than 6 nanograms per ml indicates that ovulation has taken place. Now, what about serum luteinizing hormone? Now, for serum luteinizing hormone, daily estimation is done at mid-cycle to detect LH. Ovulation occurs about 4 to 36 hours after the peak of the LH surge, coincides with about 10 to 12 hours after the LH peak, and LH is secreted in the kidney. Next slide. Cervical mucus study. The cervical mucus contains glycoprotein. It has certain properties such as viscosity, flow, elasticity, capacity to draw in the thread, which is known as spin bucket, and thickness. The characteristic of the cervical mucus is regulated by the circulating levels of estrogen and progesterone. Assessment at the time of ovulation period for spin bucket, cellular content, and fanning is essential. Next slide. Endometrial biopsy. In the past, endometrial biopsy used to be done to detect ovulation. It is done between day 21 and day 23rd of the cycle. It detects the presence of secretory activity in the endometrial glands and therefore predicts functional integrity of the corpus luteum. But it's no longer useful because the advent of highly sensitive quantitative assays, it is easier done by measuring serum progesterone level. Next slide. Postcoital test. It is used to assess the ability of spermatozoa to penetrate the cervical mucus. The couple, for you to do the postcoital test, couple is advised to abstain from intercourse for 2 to 3 days. And it's best done as ovulation is close. Endocervical mucus is aspirated from the cervix and assessed after a few hours. Next slide. After coitus, the mucus is assessed. A positive state is said to a test said to be positive when there are at least 6 spermatozoa per high power field with forward progressive movement. And when there's a symbiote of more than 6, so the rule of 6, when there's at least 6 spermatozoa per high power field with forward progressive movement, and when the symbiote is more than 6 centimeters. A negative test may be due to 1, poor cervical mucus, 2, inappropriate timing of the test, 3, presence of the sperm antibodies in cervical mucus result from infection and trauma. Next slide. For the female factor, what are the investigations you do? You do the seminal fluid analysis. You also do the sperm function test, which will include sperm penetration, human zonal binding assay, computer-assisted sperm analysis, acrosine and acrosome reaction biochemical test. You also do hormonal assays such as follicle-stimulating hormone, luteinizing hormone, free testosterone, and prolactin levels. High levels of follicle-stimulating hormone and luteinizing hormone indicate testicular failure. Low levels suggest hypogonadotrophic hypogonadism, such as Kalman syndrome or Klinefelter syndrome. The spermatozoa is not producing enough, and then the other hormones are not producing enough. Next slide. The other organs. Next slide. Urological evaluation. Sometimes you may require to do a transrectal ultrasound or vasography, which is a radiological study done to evaluate the geographic duct obstruction, or even the vesicular biopsy to differentiate between obstructive and non-obstructive azoospermia. Testicular tissue is preserved for future use in EVO-X. Genetic evaluation or karyotype analysis. To detect cause of azoospermia, such as Klinefelter syndrome, macrodeletion of the long arm of Y chromosome is important. Next slide. Now, for SFA, seminal fluid analysis and microscopic culture and sensitivity, it requires abstinence by the man for 3 days, and the sample should be collected by masturbation in a clean white mouth container and should be sent to the lab as soon as possible. The final diagnosis is based on the quality of semen, which should be made after 3 consecutive analyses, at least 3 weeks apart. So we can repeat seminal fluid analysis in 3 weeks. We can do up to 3. When the results are consistently saying the same thing, then it means it's true. Next slide. So what is the WHO seminal fluid analysis parameters? 1, the minimum volume of 1.5 mils. It should visit and it should liquefy within 30 minutes with a pH of 7.2 to 7.8, count of at least 50 million per mil, with motility of more than 32% progressive and non-progressive motility, and morphology more than 4%, you have normal form, and the white blood cell count less than 1,000 mils per mil. Next slide. According to the manual for the examination of the human semen and semen for cervical mucus interaction, published by the WHO in 2010, the most frequently examined parameter is a seminogram for evaluating semen quality are 1, liquefaction. After the semen coagulates and need to be reliquefied. Use normal conditions, system stays. Use normal conditions, the system stays liquefied. Semen stays liquefied for a total of 6 minutes after ejaculation. Viscosity, if the semen is too viscid, this could be due to prostate dysfunction. Volume, the volume of an ejaculate after 3 to 5 days absence approximately 1.5 minutes. A lower value is called hypospermia. Next slide. Semen is usually an opalescent, slightly yellow color. When color is slightly different, the possible cause should be studied. pH. The pH should be above 7.1. The pH should be above 7.1. Lower values could be a sign of azoospermia, which is absence of the spermatozoids or chronic inflammatory process. Spermatozoid concentration, normal value of at least 15 million per mil of ejaculate, but at 9 million in the entire sample is acceptable. If the values have not reached, this is case of oligozoospermia. Motility. The percentage of motile spermatozoids and those that would progress motility, those that are mobile to travel, is assessed. Motility is considered normal when at least 32% of the spermatozoids have progressive motility. If not, it is called actinozoospermia. Then vitality. A percentage of living spermatozoids should exceed 58%. The percentage of living spermatozoids should exceed 58% of vitality. It means any value lower than this is called necrospermia. Morphology. Examples can be seen of both normal spermatozoids and those with different abnormalities, whether it is in the head or the tail. Semen considered normal should have at least 4% or more normal spermatozoids. Cases in which this value is lower are called teratozoospermia, leukocytes. If leukocyte concentration is higher than 1 million per mil of sample, this could indicate an infection. Anti-sperm antibodies or MAR tests, they detect the quantity of spermatozoids joined to other cells or particles. If more than 50% of spermatozoids are found joined in this way, it could suggest an immune problem. Furthermore, the latest WHO manual established the concept of the lower reference limit. Those values found above the limit do not guarantee successful fertilization and a subsequent pregnancy, but chance increases. The lower reference limit has been on decline over the years due to general social habitat, new lifestyle characteristics such as diet, tobacco. Next slide. So what is the nomenclature? When the sperm parameters are normal, it is called normospermia. When there is no semen or ejaculate stored, it's called aspermia. When you have complete absence of spermatozoa in the ejaculate, it's called azoospermia. When you have counts less than 15 million per mil, it's called oligospermia. When the count is more than 350 million per mil, it's called polyzoospermia. Next slide. When there is reduced motility, it's known as actinozoospermia. When more than 70% of the spermatozoa are normal morphology, is called teratozoospermia. When there's increased white cells in the semen, it's called leukocytospermia. When the spermatozoa are dead. Now, leukocytospermia is characterized by increased white cells in the semen, while necrozoospermia is due to dead or motionless spermatozoa. When you have oligoactinoteratozoospermia, means you have all the three problems of motility, count, and morphology in the same sample. Next slide. Counseling in the treatment of infertile couple. The counseling of an infertile couple should be empathetic. First, you need to be a good listener for him to be able to hear them express their frustrations, and therefore it will enable you to gain their confidence. And when you're going to talk to them, you should counsel them and empathize with them, not sympathize. And then look at the issue as a couple problem, not that of a single partner. And clearly chart a protocol of care and possible outcomes. Allow them opportunity to ask questions, make other inquiries, express their fear as much and as clearly as possible. And let the couple join support groups if they so wish to. Next slide. Next slide, please. Hello? Next slide. What happened? Hello, what happened? Yeah. The next slide. The infertile couple should be categorized into 3 groups. Those with a single defect in one partner, those with multiple defects in one or both partners, those with no apparent defect in either partner. Number 3 is those with idiopathic or unexplained infertility. Number 2 is those with multifactorial infertility. And number 1 is those with single factor infertility. Next slide. So treatment. The treatment depends on the underlying cause has been identified through your thorough history examination and appropriate investigations. But the general measures include 1, cessation of smoking for those who smoke cigarette, limitation on the quantity of alcohol consumed, weight loss in women with a BMI of over 30, preconceptional dietary supplementation, folic acid to reduce the risk of neural tube defect and other conditions. Anomalies, especially in women who are. Next slide, please. Then, of course, you provide appropriate treatment, which could be medical, surgical, or combined, or even assisted reproductive technology. When the above 3 are not possible, all the above 4 treatment modalities are not possible, you can advise the couple to seek for adoption. All right? Medical treatment will include the use of ovulation induction, which can be started from hyperprolactinemia is a problem. We give dopamine antagonist to treat the hyperprolactinemia. If it's difficult, anovulation, you can give your start from oral drugs like Clomid, letrozole, with or without additional use of insulin sensitizers such as metformin. You may also end up resorting to the use of gonadotropin injections. And then, if this don't work, you can now go to assisted reproductive technology. Sometimes, right from the beginning, the patient is not a candidate for the use of ovulation induction alone. Now, you may also offer surgeries. If you have a patient with unexplained infertility, you can't find anything, but she has fibroid, you do surgery. Remove the fibroid, she may conceive. If she has distal tubal abnormalities like hydrosalpinges, you can simply do cuff saphengostomy, either open or laparoscopic. If she has periturbal adhesions, you can do isolysis, and she may conceive. But if none of this will work, if she has multifactorial infertility, has tubal infertility, she has age is against her, or the husband is also has a borderline abnormalities, the best option is to refer them for IVF, assisted reproduction. That will be better. Next slide. So treatment depends on the underlying cause. Next slide, please. Hello? Next slide. Next. For the male partner, you may need to provide hormone replacement for hypogonadotrophic men. Also, if a man has hypogonadism, you need to use clomiphene. The man has hyperprolactinemia, you may also need to use dopamine antagonists to treat it. Now, you should be aware that testosterone supplementation has been shown to have little or no benefit. You can also offer surgical therapy. If a man has varicocele, you offer varicocelectomy, which has been shown to improve sperm quality by 50 to 70%, and the pregnancy rate, increase the pregnancy by 20 to 50%. For a patient, a man that has had previous vasectomy, you may offer vasovasostomy, even though this procedure is associated with poorer outcome. Next slide. For specific infertility factors, when you have anovulation, you can use drugs such as clomiphene citrate, tamoxifen, staclophenil, gonadotrophins, bromocriptine. When you have endometriosis, you can treat with leprolide, acetate, Zoladex, and other gonadotrophin releasing hormone agonists or antagonists. If there is Sheehan syndrome, danazole is no longer advocated. Danazole produces irreversible virilization with voice changes that don't return to normal for the woman. If the woman has Sheehan syndrome, you may use hydrocortisone. Then if it's in terms of the issue of fertility, you may use gonadotrophins to stimulate ovulation induction. So next slide. For uterine factor, they do myomectomy for uterine fibroids. We do isolysis for Asherman syndrome. For peritoneal factor, you may do saphengolysis, periturbal isolysis, ovadolysis. For cervical infant, you may also consider IVF and embryo transfer, in vitro fertilization and embryo transfer. For cervical factor, you can do intrauterine insemination so that you deposit the sperm above the level of the cervix. You also consider in vitro fertilization and embryo transfer. For unexplained infertility, you reassure the patient. You reassure the couple. For unexplained infertility, you reassure the couple, and you may also offer them intrauterine insemination or IVF and embryo transfer. Next slide. What are the psychosocial effects of infertility? Infertility constitutes a significant social crisis in African community, in African family. The reason is we place high premium on birth. Especially, this pressure is much more on the female partners in a couple. And the attendant, this results in attendant emotional, psychological, cultural, and social burdens that drain the couple, especially the female partner, and result in loss of self-esteem and self-confidence. Sometimes the unsolicited and often impatient societal demand and expectation that's placed on such couples produces immense pressure and stress. And this may also worsen the cycle. Remember, in a woman, psychological stress can lead to hypothalamic anovulatory infertility. So that enormous stress imposed by the in-laws, the neighbors, the gossips, and everybody can be a significant stress, and they may become isolated and neglected, and therefore withdrawn from the family, the society, and can lead to profound depression and other psychiatric mental health challenges. Next slide. Of course, this issue of denial. Initially, all couples are associated with it. When they have an infertility, especially when you have a diagnosis, you see they'll be in denial. It will take a while for them to come to terms with the reality and come to seek for care. Sometimes they'll even go and seek for care elsewhere, look for alternative methods before they come back to you. All right? The stress due to infertility can affect the ability for the woman to concentrate, can result in amnesia, or problem of memory. And if she's in school, it will affect her performance in school. Of course, it can lead to social withdrawal because of avoidance of social situations where there will be people with children. And of course, they will isolate themselves from women who have children, who are pregnant, who are children. They develop self-hate, right? And feelings of regret. Why do that is? And then, of course, sometimes they'll start feeling guilty for something that happened in the past. They may not even be related to the infertility. Next slide. So this anger and guilt, and then they lead to helplessness and hopelessness, which is married, lead to depression, marital disharmony, even domestic violence, divorce, repeated marriages, and of course, repeated infections. Now, in extreme circumstances, there will be marital disharmony, and the more extreme are the most extreme circumstances, there will be violence between the partners, especially when the infertility is due to one of the partners, not the two. Next slide. So this is an MCQ. Infertility is a problem of developing countries. Secondary infertility is a predominant problem in the developed countries. Primary infertility is a predominant type in developing countries. Male infertility is on the increase. Treatment is usually easy, especially due to male factor. So what's the answer here? Choose the simple best answer. So question 2. Causative factors for primary infertility include chromosomal abnormalities, endocrine abnormalities, environmental factors, congenital abnormalities. Difference 1 and 2. Next slide. All are testicular cases of infertility except 1, heat, varicocele, testicular torsion, immunological causes, single gene mutation. So which one is single gene mutation? Now, endocrine causes include 1, impotence, gonadotrophin deficiency, obesity, thyroid dysfunction, hyperprolactinemia. Except impotence. Next slide. WHO 2010 parameters for semen, sperm count 20 million or more, motility 60% or more, morphology 4%, validity, vitality 70%, total count 39. True or false? Except 1. The first one is 15 million or more. Likewise, motility is supposed to be 32% or more. Morphology 4% is okay. Total count, vitality is the same. They're okay. Nomenclature of sperm cells. No more spermia, yes. Aspermia, yes. Azoospermia, yes. Oligospermia, yes. Polyzoospermia, yes. This is true. Next slide. So in conclusion, infertility continues to be an important presentation in our gynecological clinic, accounting for more than 60%. The incidence of infertility is approximately 10%, but varies depending on the geographic area. And in Africa, infertility coexists with high fertility rate, and both are prevalence of public health concern. So any question, please? So let's pray and come back, please. Let's pray, Ashley, and come back. Okay? Let's come back in 20 minutes.
Good evening, sir. Good afternoon, sir.
Yes, good afternoon, Alima.
Oh, okay, sir. Then we come back in 30 minutes?
Yes,
Okay.
20 minutes.
Okay, sir.
Thank you.